Hello, and welcome to our third session of Ancient Wisdom for Wellness Today. And we've been really celebrating some of the different topics that we wanted to talk about during Black History Month. This year, the first week was about critical race theory. The second week was about the wealth gap that happens in this country and around the world related to Black and Brown people. And today we're going to center in on healthcare. I'm going to pray for us, and then I'm going to ask each of our guests to introduce themselves and talk a bit about what they do and how they feel they were called into this field. So if you would take a moment and pray with me. Dear Heavenly Father, we are so grateful for you in our lives. I am just bubbling with pride to see the beautiful faces that you've called into the health field. We ask you to cover our conversations, Lord, today, that someone is blessed by what we communicate today. We ask you to guide our words and our thoughts and strengthen us through this conversation. We asked it in Jesus' name, amen. So I would like to let you know that we have folks who are part of the healthcare field. We have Dr. Nia Jones Stallworth, who works in a major medical center in pediatrics here in Alameda County. And we have way across the country, Akilah Witherspoon, who is a certified doula and also works in educational training for women as they go through childbirth and also health education. And we have Esker Ligon, who is a psychiatric nurse practitioner in San Francisco. So welcome. Maybe we can start with Dr. Nia and tell us a little bit about yourself and how you feel you've called into this field.
Sure. Okay. I'm so happy to be part of this panel. This is a topic that's very near to my heart, as I kind of always wanted to be a doctor. Well, not always, but since I was about 16, I wanted to be a doctor, and I kind of went through medical school not really knowing exactly what I wanted to do, but I was just drawn to pediatrics because who doesn't love kids? And I'm basically a big kid. If anyone knows me, they know that. So I felt like I fit right in, and particularly kids of color, I felt drawn to serve that community. So my clinic is actually in Hayward, and we have I have a really diverse practice there. So I'm happy to be doing what I feel called to do.
Thank you. And next, Akilah Witherspoon.
Hi, greetings, everyone. Thank you for allowing me to be a part of this conversation in this panel. And I'm excited to be able to share whatever information I have and whatever I know. But the way that I got into this field, life kind of pushed me in this direction. I originally was pre-med and I studied biology in undergrad with the intentions of going to medical school. I went to Howard, so that's how I made it over here on the East Coast. I'm over here in Maryland, the DMV, close to Washington, D.C., and I actually grew up in California, so I'm excited to be amongst Californians tonight. But I went to undergrad intending to go to medical school, and when I graduated, I worked in the hospital with the OBGYN studying fibroids, and at that time, I kind of was on the fence about when I was going to start medical school because I wanted to be strategic about how I planned it. And I also was interested in holistic health. And I did undergraduate research and I shadowed with physicians. So I kind of knew what I would be expecting to go to medical school. And I wasn't sure like how I wanted to approach that yet. But then I got life changed, my path kind of changed. I got pregnant, which I was not very happy about that at the time. I was very angry, and it kind of like, it changed my focus and how I was going to be able to move forward, because now I had different priorities and also had family responsibilities. And so I began thinking about midwifery. And I guess I'll tell you guys a little bit more later about what midwifery is and when we talk about history. But at that time, I wanted to go to this program that was in El Paso, Texas, but I did not really have the support to go there at that time. And so I found out about a program to study to become a perinatal community health worker, which was a program in Washington, D.C. through a nonprofit called Mama Toto Village. And the mission was to be able to provide childbirth services and education and doula support to families and women who don't normally have access to that because of the barriers. And so we worked in the more impoverished communities in DC, particularly like Ward 7 and 8. And we worked with them prenatally, providing education, attended births, provided postpartum support, as well as community support. So helping them access resources such as food stamps and housing. And some people were experiencing domestic violence. So I really worked, with people that were experiencing a lot of trauma and still trying to navigate birth. And so I worked there for about 2 years, and then I was able to transition on and kind of further see how I would work in this field and be able to support families. So I worked with families with parent-child interactions and helping them be able to bond with their children and make sure that their babies were on stage for their developmental age. And eventually I decided that I needed to be an entrepreneur, because working for other organizations, it comes with there's a lot of stuff attached to working for others. And so at the beginning of the pandemic, I transitioned into having my own business. And so I support families as a doula, but I also am a certified childbirth educator. And so I do childbirth classes, and I am a doula trainer for the National Black Doulas Association. And so I get to support other women and other, not even just women, but whoever wants to become a doula and support families. And basically, just to let you know what a doula is, doulas provide emotional and physical support to families, to women during labor, in the postpartum period, and prenatally. So wherever they need support, doulas are able to help in those different areas when they're pregnant and after they've given birth.
Wonderful. And Esker? You're on mute.
Okay, no, I was unmuting myself. Good evening, and thank you for the opportunity to participate in this panel. My name is Esker D Ligon. I am a nurse practitioner. I primarily work as a psychiatric nurse practitioner, but also hold a certification as an adult nurse practitioner. Kind of what led me into this role, I decided when I was 15 that I wanted to be a nurse. I had family members with chronic conditions, one in particular, a cousin with sickle cell. And so I would often spend kind of summer vacations and things of that sort from school. If she was in the hospital, I would be there at the bedside because they allowed for, someone to be there with her during the day. But just seeing the way that nurses were on the forefront of providing care for people kind of resonated with me. So from that point on, once entering the field of nursing, seeing that people were often stigmatized and treated differently. I started off on a med-surg unit. My passion was always to do psychiatry. When we did clinical rotations, it just seemed like the area of healthcare that fit for me. Because you really use a lot of yourself in connecting with patients that you're working with, and no one is ever the same. It really allows you to be creative in your approach, really looking at solutions for someone. So that's kind of what drew me into psychiatry, but working in the med-surg unit, often seeing how people with mental health conditions were often coming in with out of control chronic health conditions. And so really wanting to get on the other side of it as a nurse practitioner, where the focus often is on prevention and maintenance versus when they're in the hospital, we're trying to repair something and restore health. So completed a program of study at the time. There was a dual focus program at UCSF. So I completed that program. For the first 10 years of my career as a nurse practitioner, actually had the opportunity to work in community health settings in the Tenderloin area of San Francisco and provide both primary care and mental health along with substance abuse services. And now currently working in Vallejo, and where my focus is mostly on psychiatric services. And so I'm going into my 18th year of doing this. And so it has been very rewarding. Just being able to really connect with people and see over time, seeing people make change, and really seeing someone who came in a condition where they're really fragile to where they're leading more productive lives at times. And so that's really what keeps me drawn into it and keeps me going. And then I'll talk about some of the other aspects of what I do kind of later on in the panel.
I have to apologize. I thought it was San Francisco, but you're in Vallejo now, which is...
I'm in Vallejo now. But
okay, wonderful.
The first half of my career, I was in San Francisco.
Wonderful. I think I wanted to touch on some of the history related to medical care and coverage for people of color. I came from a huge family, and I think every one of my siblings' births were home births, because whether or not my parents had the funds, or whether we were living in a place where we weren't necessarily able to have hospital delivery, that was my history. And so there was a little bit of midwifery going on and some doula experiences, but I don't think it was called doula then. But maybe I thought we would touch on some of the things that have you seen as disparities in the pediatric department, maybe PTSD in young adults and children, and also some of the disparities in midwifery and doula. So maybe each of you can talk on that. And it's okay to cross-conversate too. If you have a question for one another, that would be great as well. I think that would add to the conversation. Anyone can start, it's okay.
I can start. So, in thinking about this, there's so many things, but I kind of wanted to hone in on a couple of just things that I see like every day. So, one thing is asthma, obesity. Those are kind of, I wouldn't say the only chronic diseases, but the two main chronic diseases that I see in pediatrics like all the time. And there's definitely disparities between Black kids and kids of color and white kids. And I would say there's so many different factors that cause it, but just looking at some of the statistics, Black kids are 5 times more likely to be hospitalized from their asthma, more likely to actually pass away and die from asthma, and just have more frequent clinic visits, more calls to the clinic, more messages and all of that. And then with obesity, it's definitely become worse during COVID. And I think that would be a whole different discussion on all of the causes of that. But about 15% of white kids have obesity versus like 25% of our Black kids. So there's huge disparities in those two things. And so many other things, ADHD, so many things, but I'll leave it there so everybody else can talk.
So I guess I'll go next. And looking at different disparities. And as she said, there can be so many different examples of things that we see on a daily basis. One of the things that I'm starting to notice isn't so much the tendency towards mistreatment in psychiatry. It's I sit in the position where I can see how people are being mistreated with regard to their chronic conditions or their other healthcare concerns. When there's a diagnosis, a mental health diagnosis on the chart, sometimes people are treated differently. And that's kind of universal. However, it is much more glaring when it is a person of color. Where I've seen people come in with the exact same diagnosis, some of the exact same findings on imaging or x-rays, and totally different course of treatment. The person of color being told that, no, this treatment isn't necessary, whereas someone of European descent is getting all of these other services. And so really being in the position to have to advocate for people to receive those extra services that they might need. Instead of them being brushed off as, oh, this person has a mental health condition and this is what's the cause of this illness. And what we are taught when we are going through training is that mental health conditions to a certain extent are diagnoses of exclusion when certain things are going on. And so without certain things being worked up, how do we arrive at and say, no, this is all because of their mental health? So that's one of the kind of disparities that we deal with on my daily work. But one of the other things is really dealing with access to care and health literacy. There's often a tendency for people to be given a diagnosis and not having an explanation of what that is. And what we're finding out is because there is a huge stigma in communities of color about even talking about mental health issues, seeking mental health care, people are often told nothing is wrong with them. And so when you get there and we're finally trying to have this conversation and say, well, these symptoms go along with this disorder. When people don't have an understanding of what that diagnosis truly means, they just heard it's something bad. And so the resistance that, no, they don't have this because that's really something bad, and they have a concept in their head of what that looks like. And so really a lot of work being needed as to try to educate people on, how to ask the right questions, how to actually read the information about a diagnosis instead of just being resistant to it. And then the other thing that really makes it difficult to access care is, one, that there's a shortage of mental health providers, period, nationwide. Estimated that in California, if we keep with the current trend of providers being over the age of 60, the majority of providers in the workforce are nearing retirement age. And so it's predicted that there will be over a 40% shortage of providers by 2028 if we keep with the current trend. But within that, there aren't providers that look like the community. And so there is even more of a shortage of providers of African American and Latinx descent. And so often people want someone who looks like them. So that's another barrier to care, that they get in there and they think that someone doesn't understand them. And who do they turn to? And so that's not available. And so I'd say those are some of the more glaring things that I see as far as some of the disparities that we deal with on a day-to-day basis.
Thank you.
Okay, so I know when we talk about birth and health in the United States, a lot of people are aware that there's a disparity between the birth outcomes for people of color and for people who are not of color, and especially for Black women. A lot of Black women and babies are experiencing high death rates or harm rates when giving birth in the hospital. And so in light of Black History Month, I think it's important to really highlight the history of birth care, midwifery, and health in the United States, and talk about what birth was like before the hospitals came in and decided that they want to take over. Before, and it's Miss Elder Norma, you mentioned that your mother gave birth at home, and that was pretty much the option that was available. So when we think about birth in the United States, a lot of people associate birth with giving birth in the hospital. You expect to go to the hospital and follow whatever protocols are there. But prior to the early 1900s, birth happened for everybody outside of the hospital, and particularly for Black people, because as hospitals were being built, and as the medical field was taking over various areas of health, Black people were still not allowed to birth in those spaces. And so talking about, there still had to be an option for people giving birth outside of the hospital. And so prior to the medical field coming in, the majority of births were attended by midwives, and midwives are they're clinicians, so they're able to do pretty much what an OB does. They catch the babies, they're able to do vitals, they're able to take blood pressure, all of the things that you would expect a clinician to do. And so just to highlight, I'm a doula, and doulas are different from midwives, where doulas are not clinicians. We provide emotional and physical support, but the midwives are the ones who provide that medical care. And so in the early 20th century, Black women were attending births for Black people. And there was a lot and I don't know if you guys are familiar with granny midwives, and some people refer to them as grand midwives, but these granny midwives were a generation of midwives that were attending births right during that period of time before it was outlawed. Midwifery was outlawed in the United States, and birth was primarily being attended in hospitals. And so there's quite a few books out there on some of these women and the work that they did in the community. There was a film in the 1950s that was, it was directed by it was funded by the Department of Health in Georgia, because they wanted to be able to provide training for midwives in that area. And so a lot of the women who practiced midwifery, they came into that field because they were called, and it was a lay, pretty much was a lay field where you were an apprentice and you studied under somebody else that was a practitioner in that field for a long time. And so when hospitals first started to have, when births were happening in the hospitals, they needed Black women to go and attend these births so that Black women can still have safe births outside of the hospitals. And so they were, communities were training and paying for lay midwives to go through this training. And then around between the 1950s and the 1980s, the United States went through this mass persecution of midwives, particularly Black midwives. It affected all midwives, because these women who were healers and attended births in their communities were often associated with being witches, and they were being persecuted. And so for Black people, it was even more dangerous, because we were experiencing racism in the hospitals, barely being allowed to go in there, but then they would outlaw the field that was dominated by Black women who were providing maternity care and having very low maternal and infant death rates. Miss Mary Coley, who the film, it was called All My Babies, the film that was that came out in the 1950s, she attended over 3,000 births, and she had very few mortalities. And when you look today, United States being considered a first world country, an industrialized country, and we have the poorest birth outcomes of all industrialized countries. And it's because of, a lot of it has to do with racism and access to care in the United States. And so now that medicine and the hospitals have taken over birth, and we're starting to see more people know about midwifery and taking births outside of the hospital, but there's still not very many midwives in the United States. And of those, there's about 15,000 midwives in the United States, and less than 3% of them are Black women. And so when we look and see that there's still this high mortality rate for Black people in the hospitals, you can't address that issue without addressing the fact that the people who provided this care previously were disenfranchised and pushed out of the field that required you to learn under somebody who was skilled and had knowledge and worked in that field for a long time. So a lot of these women that were persecuted, these granny midwives, were in practice for over 30 years. And there's a story of Gladys Milton in the 1980s. She was sued by the state. They sent her a letter and said, thank you for your service to the community, but it's time for you to retire. And at that time, she wasn't ready, because she knew that the women in her, she worked in a rural area, and people still needed her support and still needed her care. And she was highly regarded and respected in the community, but they wanted to push her out because they wanted to outlaw midwifery and allow only hospitals and physicians to attend births. And so we kind of have to look to see, in order to kind of deal with that situation, because now there's a lot of, when we look at, for example, Kamala Harris, the vice president, she had a maternal health summit earlier or at the end of the year to address the issue. And they have the Momnibus Act and the Build Back Better Act, and they're trying to figure out how to improve birth care and how to reduce the infant and maternal rate. But you can't really address it without looking at the history, looking at disenfranchisement, and then looking at the models that allow people to have safe births and to be able to have good birth outcomes. So
thank you. Was some of that move, as far as getting rid of the midwifery portion, have anything to do with money? Because if you brought that delivery into the hospital, then you can collect another fee that otherwise you would be losing out to a woman who's been practicing for years. Does any of that come into play? I just thought about that.
Yeah. So I think finances, when you think about it, health is $1 billion industry in the United States. And that pretty much, a lot of the things that we now see in healthcare is because they want to be able to maximize on profits and maximize on the amount of money. So birth is a part of the healthcare system. And so when you look at the healthcare system as a whole, money is one of those top factors in the funding, and even just the fact of having to keep people sick and having to have, it gives money, it puts money in people's pockets when people are sick and have to pay out all this money. So having a home birth, a couple of $1,000s, but a hospital birth, they can charge you $10,000. And even for the mother and the baby, you'll get 2 bills for the same thing. There will be a room bill for the mother and a room bill for the baby, but they're both occupying the same space. So it's all connected to money when in the United States, I think.
Yeah, thank you. Yeah. One of the things I wanted to ask you, Nia, was related to when you say obesity and diabetes. And is there any studies or any efforts to bridge that gap between
Well, we can't hear you. Are you, you're not muted, but.
I'm sorry.
Okay, that's better.
Is that better? Okay. I wanted to ask you, because you talked about diabetes and obesity, and I was wondering, have there been any studies related to, as far as Black and brown children really being in toxic neighborhoods, being exposed to food deserts, so that even if they wanted to have healthy meals, those are not available to them readily, especially if they don't have transportation or access to.
Yeah, I don't know any great studies off the top of my head, but that's definitely one of the major factors that contributes to obesity is, obviously if you don't have access to fresh fruits and vegetables, to good health education, then, it's going to lead to obesity. I'm trying to think there's any promising studies. And one interesting thing that I want to touch on is, even when you provide those things, like the healthy food options and safe neighborhoods where kids can walk and safe playgrounds and all of that, there's also a tendency to look at kids as separate from their families, as separate from their communities. But interventions that target both the kid and the family as a whole and the community as a whole are way, way more effective. And also that target like the mental health issues that are super, super prevalent right now, because your mental health is like very tied to your physical health. And when you have that, if you have a high stress environment, that stress lives in your body. It causes higher cortisol levels. It's going to make you crave those high fat, nutrient poor foods, and that's going to drive up obesity too. So I don't know the studies, but the food deserts and the environment definitely plays a role, but it's not just that. It's, you have to address so many different things to really keep kids healthy.
Yeah, it's so big. It's so big. I was listening to Esker. I wanted to address you. I was listening to a TED Talk with Nadine Harris, and she talked about the ACEs. And what was so interesting in that talk was that the study was not done in a Black and brown neighborhood, but it was actually done in a predominantly white neighborhood. And so it says that those factors can be healed if we take the right approaches. And so I wanted to have you talk a little bit about what you've seen and what kind of things have affected the work that you do when it comes to PTSD.
And just to do a quick summarization of the ACEs study, it was a study originally conducted by Kaiser Permanente, Southern California, 1995 through 1997. And so in a nutshell, what they found out was that people who had been exposed to adverse childhood experiences, there was a correlation with them having chronic health conditions and other negative health outcomes. In more recent years, people have really looked at that study and have found other correlations. And so I had a colleague of mine who did her PhD dissertation on transitional age youth and their occupational hazards that they encountered, and correlated that with people who had a higher number, who actually experienced ACEs, had more trouble with educational attainment, and with occupational issues, whether they were getting injured on the job, able to retain employment just to be successful in the workplace. And so there have been all kinds of other studies who have really taken a look at ACEs, and the clinic that I work in. High numbers of people experiencing trauma. And so we even took a look at it in comparison from one site in our service area compared to another, and found that we had all of these people that experienced adverse childhood experiences. And so looking at how is that really contributing to their poor health outcomes? Is this what's making it more difficult for them to get their symptoms treated to what we call remission, to where people are able to function and not be bothered by their symptoms? Because one of the things that we learned from looking at the ACEs, because it turned into, we had to do a universal screen, practically universal screening on almost everyone who came in. What you find is a lot of people normalize that. So they didn't perceive it as something being an adverse experience or a form of trauma. And so people learn to just deal with things and not realizing how internalizing that has caused some changes, has affected the way that they cope, affected the way that they interact with others, their healthcare habits. And just kind of on the basic level, when you've been exposed to trauma, experiencing trauma, that there are chemical changes that happen in the body. Because the whole fight or flight response, is getting triggered so many times that, to simplify things, the feedback loop has been thrown off. And so there are people in this constant excitable state. for whatever reason. Some people are more resilient than others, but if you even take a deeper dig into that, even the people who seem to be the most resilient, you can still find areas in their life where they have difficulty. Mm-hmm. A lot of the studies or the kind of the protocols that we look at, they like to try to say, oh, well, it's weighted. And certainly the more experiences someone has been exposed to, the more difficulties they may encounter. However, there are some instances where a person has only had one adverse experience and it left such an impact on them that they may be worse off than someone who's experienced 3 or 4. So we can't always look at that strict correlation and say, oh, just because they only had one, well, they should be all right. They shouldn't be as bad off. It's not always the case. One of the things that I think from Dr. Nadine Burke-Harris's work as the Surgeon General of the state of California is there was really more of a focus placed on doing these screenings more universally. Also implemented kind of protocols for really looking at how do we build resilience. So once we've identified that someone has experienced these things, what do we do to really look at building resilience? How do we look at wraparound services, especially when we identify these things when people are young, to kind of really undo the damage so that they can go on to lead more productive lives? It does become a challenge when someone's an adult and they've kind of had these impaired coping abilities and the damage has already started to be done, to really try to unravel that and teach people a new way of looking at things and really trying to look at, okay, what can we do to build your sense of resilience from here? And how do you put this behind and move forward? And one thing that I always tell people is easier said than done. I can tell you, okay, you need to really learn how to refocus and reframe things, but it's not that easy to tell you to stop doing something that you've been doing for 30 years, because that's what you know. But looking at the numbers of people who end up with things such as unwanted, unintended childbirths, substance use issues, even people who are more, for whatever reason, more prone to having traumatic brain injuries, being in relationships characterized by intimate partner violence. And so there are a myriad of different health outcomes that can be impacted just by someone having these adverse childhood experiences. But really kind of optimistic that it's been brought to the forefront so that people can really be more diligent about providing trauma-informed care, and really looking at what are some solutions and preventative measures to keep people from getting to this point.
Yeah. Like we said in the beginning, it's all so big, so big. Let's maybe talk a little bit about some of the things that you see are hopeful. I know we've talked about maybe there's not enough pediatric doctors or doulas or care nurses that are able to provide what I think could help as we move forward.
I think I heard your question. You were cutting out a little bit, but I heard, like, what are the hopeful things that we see? One thing, as you were talking, Esker, about the universal screening, that's one thing that we started to do in our clinics. And I think it's really just taken off over the last 10 years, maybe. And even the last couple of years, it's become even more widespread. Like, I don't know the details about clinics outside of Kaiser, but I know within our Kaiser clinics, we're screening every single kid who comes in for a checkup. They get the ACEs screening, and we're trained, the providers are trained on how to respond. Because I think part of the difficulty is, you do the screening and then now what? It's like, I have 10 minutes left for this visit and, don't have time to address everything. So that's hopeful that there's training on ACEs and universal screening. The other thing, I think you were saying too, Esker, how just some people are more resilient than others. I find it hopeful that resilience is something that you can build, and especially in like a small child, you can see them go from just like really dysregulated and can't even respond to a small stress like getting a vaccine, to like a completely different kid, just by helping their parents or helping their caregivers learn how to manage the kid's stress, how to manage their own stress. So that's something that I've been able to see, just getting people the help they need, especially mental health services that they need, makes a huge difference. Oh, well, the other things, there's definitely some innovative programs out there, like for the other things I was mentioning, the obesity and the asthma. We have a education program where the pharmacists actually partner with us and look at all the data and like look at which kids are falling through the cracks, which ones are coming to the ER so many times, and they have those kids in a certain list that they go through, and they reach out to them and provide just extra education and extra services to help them really know how to use their inhalers, which ones do I use, when do I use, and all of that.
So I guess I'll go. So I think some of the positive things that are happening now is that people are they have a greater awareness for, when we talk about holistic and having better experiences and taking charge of their health. And so the conversation, and especially with childbirth, like we're now, for a period of time, it was hard to find a midwife or hard to find an option of birth outside of the hospital. And even hearing about doulas, when I had my daughter 8 years ago, I did not know what a doula was. I knew what a midwife was, but I didn't really hear any information about a doula. And now in 2021, 2022, like a lot more people know what doulas are. A lot more people have access to midwifery care. And now you're hearing conversations on a national level, like Kamala Harris, her platform is, she's really trying to take advantage of that opportunity to address this issue, because people are more aware of it and people want to be able to have better options and be able to have more funding so people can have better birth experiences and be able to access better maternity care. And then you see, like in Washington, D.C., the mayor, Muriel Bowser, she started a summit that I think is maybe the third year. I think in 2018 was the first one, but an annual maternal health summit where they talk about the issues with maternity care and programs and funding. And so now we're starting to see things like Medicaid. Medicaid is covering people to have doula support. They're covering more midwifery support. They're reaching out to community organizations to find out how they can improve their policies. I was a part of a stakeholder group with the White House where they were asking different, they were trying to find out what is needed in the communities and what programs, where they need to point their funding and how they need to improve maternity care. And so, and even just like thinking about the issue, Ms. Norma, when you talked about food deserts and, Nia, some of your patients not having access to nutritious foods. And so some of these communities and some of these community organizations in birth are addressing these things. Like the nonprofit that I received my training with, a lot of people were stuck in food deserts. And we know that a lot of the programs before that were offering free food to people, a lot of it is junk food. And so if you don't have money, if you're relying on food stamps, you're having to buy, or if you're living, like, let's say you have to live in a hotel because you're experiencing domestic violence or homelessness, and they place you in a shelter or hotel, a lot of people just have a microwave or, they have to eat food that doesn't have to be cooked. And so that limits fresh food options. But now we're seeing programs like SNAP in Washington, D.C. They're allowing people to use their food stamps to go to the farmer's market. And then some of these markets are doubling their food stamps for let's say, you get $10 for produce, they'll double it and allow you to get $20 worth of produce. So even though it's a little bit slow, but the conversations are happening, and we're also seeing that these programs that a lot of the families that are, a lot of families, Black and Brown families, are underserved and rely on these public benefits to feed their families, to access healthcare, and to be able to take care of themselves. So we're starting to see the conversation about how to improve it and how to make it more holistic and give people what they really need to have better health.
Wonderful. I missed a little bit of that. I got kicked out. So this has been so rich. I wanted to touch on the fact that I feel, and I hope you feel, that you really are God's hands and feet as you go into these communities and as you interact with these families and children. And so how do you see yourself walking through as God's servant in these places that you don't always see the best outcomes, but you're hopeful about things that you hope will change? And what kind of things do you hope to see? Ending on a good note, let's talk about some of the wonderful things that have happened and how that looks, how God has worked in those situations.
I guess I will go first with that one. I think the fact that I've been able to bear witness to some of the things that I have is in mental health. Unfortunately, we see everything. We hear everything. People come to us at their most vulnerable state oftentimes. And to be able to sit with that, one, not be burnt out by it, not have an issue with kind of having a grip on my own sanity. There has to be God in that, to be doing it for so long. But the other thing is, especially in some of the populations that I've worked with people who have been homeless and work with people who are actually quite affluent. But mental health does not discriminate. It is the one area of healthcare where it really is that you are often dealing with the least, what society sees as the least of them. And so really being in the position to make sure that these people get access, the same access that anyone else would get, is really one of the things that drives me. And as far as kind of hopefulness for the future, really looking at the fact that although there is a shortage, just as Akilah was saying, people are much embracing more of the holistic approaches. And so although there may be a shortage of healthcare professionals, people being much more willing to do things such as meditation, practicing mindfulness, really looking at what are some homeopathic remedies that they can try versus just wanting to be prescribed a pill and make things go away. So really taking ownership of their own health. And even with the shortage, really looking at the fact that there are programs that are really looking at building a pipeline of future mental health care professionals and really putting a focus on increasing the diversity of the mental health workforce. And so those are some of the things that I'm helpful for, and just feel that like it is my ministry to kind of work with this population and to ensure that better healthcare outcomes are achieved.
Thank you. Thank you.
I will say that I feel really blessed by this conversation, and I feel grateful for the work that you guys do. And it definitely feels, you can feel kind of defeated some days, especially in my role. It's like, you have these short visits and it's like, okay, God, what can I do with these 15 minutes? Like, what can I address? But I think people get it. And I think the way that I see God working through me is just being able to reassure a parent that, because a lot of times there's a lot of guilt. It's like, oh, my kids have all these asthma attacks, or they've gained so much weight, I'm a bad parent. And just like speaking speaking the truth, but also showing God's grace and love, and just reassuring them that, they're doing the best they can, and these are the things that they can do going forward. Is how I see myself in my role, is really a partner with parents to help them learn how to take better care of their kids, and help them recognize the things that they are doing right, and the things that are going well, and helping them see how they can build better relationships with their kids. And so it's definitely a challenge, but I think that is an understatement. But it's worth it, and I'm grateful to be in the position that I'm in.
So I am in this field because I was called. Like, I'm just like, when you're a kid, I think what you're supposed to do. And I knew it was something related to health, but I fought to stay in this field throughout my journey. Like, I really wish that I could have been called to do something else, because just like you said, Nia, it's a lot. And I know, Esker, you working in mental health, being a health professional and working with families that experience, because there's a lot of trauma when you're dealing with health. Yes, there's good things, but a lot of times people go to the doctors and they go seek help when there's a problem. And so when you're the service provider, we take on some of that emotionally. And when I first started in this field as a community health worker, I didn't know, I kind of just was thrown in there without any type of training or information on creating boundaries when it comes to the emotional aspect of this work and dealing with all the stuff that people have to deal with just to live. And so, another thing about me is I'm a graphic designer. I took that up when I was pregnant with my daughter, just to kind of avoid to hold my student loans. And then I found that I really loved it. And so I always tell myself, like, I wish that I found this before, I knew about my calling, but I've been called since birth to be a healer and to work in this field. So I can't run from it. So I've there's some things that have happened in my life, including the birth of my daughter, which was it was traumatic. So that is kind of how I became to be a birth worker in the first place, versus just working in health and women's reproductive health. And then dealing with my mother and my grandmother, having to go to the hospital with them a lot for various different things. So those things were difficult, but they gave me a lens to be able to have empathy and to be able to have understanding for people when they're dealing with sensitive health issues and dealing with, childbirth, and having to even deal with the other stuff that comes along with life. Like, when you're pregnant, you're not just dealing with the pregnancy, you're not just dealing with the birth, but you got family obligations, you have, trying to figure out where you're going to live, figure out what food you're going to eat. And I happen to have worked mostly with the population of people that don't have the money out of pocket to pay for those things. So it's even more traumatic. So I've tried to run away, and I was like, let me go and be a graphic designer and make my hundreds of thousands of dollars and be a developer. But God said, like, no, this is your calling. And I'm at peace with it, and I accept it. And so I'm at the point where I'm like, okay, God, like, you're going to give me all the things that I need to be successful in this area, put the right people in my path, give me the right trainings, the right experiences. So I'm here for it, and I'm being obedient, but sometimes I want to have fun and do the things that make a lot of money, but
No, but I think the work that you're doing is an important work, because we struggled as a people so long with, historical trauma that keeps us from moving forward in so many different areas of our life. And even now we have to struggle with people choosing that whole historical trauma over, in some sense, science. And so we continue to try and break those myths and dispel those myths that keep us bound into moving forward. So I just really appreciate all of you. You're just yeah, beautifully and wonderfully made. And God has called you into a field that is so important, so important. The healthcare field is something that we weren't at so long be able to take it on at this level. Even though, like Akilah said, I remember that my mother, I felt, was an herbalist because there were so many remedies that she knew from past generations to help with so many different things. And when you look at some of the products that are on the market, those products really came from those word of mouth remedies of women who took care of communities of people that look like them for so many years. So we have a lot to be proud of. And I'm so glad you could decide to spend some time with me today. I will continue to pray for each of you as you work in the field that you've been called. And I just want to thank you